Mhm. It is thinking a bit. You check us over here on Facebook. Hello, everyone. Happy Tuesday. Just doing a quick tech check. See if everyone can see us. And I see us over on Facebook. All righty. Hello, everyone, and happy Tuesday. My name is Alexis Johnson. I'm the social media manager here at RSDSA. Tonight, we are joined by someone who is no stranger to our live stream series, Dr. Anita Davis. Dr. Davis has focused her career on treating people with neurological and chronic pain conditions. She developed and managed the Brooks Rehabilitation Comprehensive Pain Rehabilitation Program for 30 years. She also serves on the Florida Department of Health Rare Disease Advisory Council and manages a support group for individuals with CRPS. She is certainly a friend to RSDSA. We shared her full bio via social media and in our emails, and I'll be sure to also put it in the chat. Dr. Davis was recently interviewed in a USA Today article that mentioned how CRPS is often diagnosed as a mental rather than physical illness, and CRPS warriors, particularly women, who seek care for CRPS symptoms are frequently misdiagnosed with mental health disorders, such as depression or anxiety. And so we're going to touch on this topic for today's live stream. We have included a link to the article in the description of this video, and of course, I'll also add it to the chat. As always, remember that while the information shared here tonight is helpful, please consult your physician for personalized medical advice. And now, before we get started, I do want to remind everyone that we have a few great events coming up. Visit the RSCSA website to learn more about them. This Saturday at 3 Eastern, we have Connecticut CRPS Awareness Roll and Stroll in Winsted, Connecticut, hosted by RSCSA board member Kelly Considine. Next month, from October 17th through the 19th, we have the 5th annual Picklin' for a Cure in Tucson, Arizona. You can sign up to play pickleball, attend, or donate. We're really excited to have that event return for the 5th year. And finally, from October 24th to 25th, we have our first in-person conference since 2019. It will take place in Irving, Texas, and will feature sessions by Pradeep Chopra, who will discuss CRPS in adults and children, Amberly and Pope, who will talk about legal issues in CRPS, and a host of others. So, of course, visit the RSCSA website to register for the conference, book your hotel room, and read the full agenda. But that's enough announcements for me. I know you all came to hear from Dr. Davis, so I'm going to turn the floor over to her. Be sure to leave your questions and comments in the chat, and of course, we will go through them at the end of the presentation.
Hey guys, cool. Full disclosure, I'm in one of those rooms that automatically controls some of the lights. So at any point, it could get really bright back here. Hopefully not. I've tried to tape over that sensor, but I thought this would be better for right now. Give me a moment just to pull up our full screen. We'll get started with that. One more click of a button, and it should be in a bigger view for everybody. Should be. Now it is. So, yeah, Alexis is right. There's been an uptake in some of the interest with not just CRPS, but a lot of other conditions being either misdiagnosed, misunderstood, or just downright missed. And you can appreciate how all of those are very possible and very frustrating. So it prompted a couple of those interviews and articles. But what I wanted to cover tonight was a little bit of more of the specifics relative to complex regional pain syndrome. What makes it likely to be misdiagnosed, misunderstood, or just plain old-fashioned missed? So we've got a few things that we can cover that might give us a hint to some of the complexity of that. The contributing factors might be that it is a rare disorder. We'll dive into that just quickly. Some of the diagnostic criteria, the red flags, and you'll get familiar with the term called differential diagnosis. There is actually some dispute in literature over the validity of CRPS. Some of the literature gets a little spicy. And then we'll close with a couple of recommendations. What do we do with all of that now that we know some more things? Maybe it's not a real news flash for us, but we know that healthcare providers, from rehab providers in physical therapy, occupational therapy, all the way to physicians, really don't understand this condition. And this is a sense of them being transparent and honest that they don't feel prepared to treat this condition either. Only 50% feel that they are adequately trained in patient care with pain conditions. 92% want more education on pain management, which is fabulous. I don't remember where I read it, but I think it's still kind of true that veterinarians actually get a little bit more training in identifying and interpreting pain than physicians that treat humans. And it makes sense. Our veterinarians have to deal with the dogs and the cats and the critters that don't have all of those words. They just have responses and reactions and behaviors that the veterinarian then has to interpret. It's a little bit crazy, but I understand why it happens. It's really nice to see how some of our other providers now are coming out with that same awareness that I don't get it. I don't understand it. There's more to it than what I know. And I wish I had a little bit more information about it. It's not a news flash. We've kind of known that in our inside guts for a long time, but it's news that they're acknowledging it. The other thing that makes this difficult is it is a rare disease. It may even be called an orphan disease because there's so few people that have the condition. Rare diseases are not unique to the United States. It's in Europe, and they also have different criteria. For us, if there are less than 200,000 cases in the United States, it is classified as a rare disease. It's only one of over 7,000. So it's a big list of a rare population, and out of that big list, CRPS is a small piece of it. What you see are some of the numbers of population studies, meaning they went back retrospectively in review, looked at charts, and pulled out the data, pulled out the information to try and identify so how many people really have this condition via a massive chart review, both in the United States and in the Netherlands. And you get the incidence rate, how many people per 100,000 have the condition. So based on those numbers, it totally validates this being an orphan disease or being a rare disease. Unfortunately, even in current literature, those data points are still reported, which means that study like that has not been redone. So I don't have more recent or more new information to share. But I think it would still definitely classify as rare. I don't even want to try to predict, has the population number increased or decreased since the early 2000s? I just know it's still there, and it probably is still definitely on that rare side. Another diagnostic challenge is the multiple criteria. It's been identified by different tests, different measures, different sets of signs and symptoms over the years. Thankfully, people are still looking at it and trying to update it and get something better. That's the good news. The bad news is it's been difficult to look back in time and see what happens to this condition because the criteria were different 15 years ago. And then not all people are using the same criteria until you get further out in the timeline. There was a point in time where a particular block, one injection, do they respond to it or not? That was the telltale sign. The bone scan, triphasic bone scan, although helpful at one point, we thought, aha, that's got to be the test that'll tell us if this is complex regional pain syndrome. And over the years, we've learned that none of those are true. They're helpful pieces of information. But the one that we operate under right now is the Budapest criteria. And here you see a big list of those criteria. Looking first at that big rare arrow, that's where the criteria start to be listed out. It's continuing pain, which is disproportionate to the initial initiating event. Pain that's worse than, greater than, longer than it should be for the typical type of injury that started the condition. Then you've got a list of other things. We've got signs and symptoms. We should have both present at the time to make the diagnosis. And if you look at some of the fine text, some of those symptoms, you need to be able to identify 3 out of those 4 listed there. For the signs, 2 out of the 4. That's a whole lot of words, and I've got a slide coming up that makes it a little bit easier. If you've had the condition for quite a while, you may be familiar with this. If you're new to it, this just may be nice, refreshing information that you can kind of tuck back into. But even when I present to other physical therapist communities, this is the slide that seems to make a little bit more sense. We've got four categories: sensory, vasomotor, sudomotor, and motor or trophic changes. And you see some of the breakout categories there. As a patient, when you come in, you've got probably all of these, two of these, three of these. That's the nice information that the physician is hoping to attain from the interview. And looking at how many of those and to what degree is this present in your condition. There's also signs that match those same categories that the physician or the therapist is testing to see, is it present and is it clinically significant? Mm. Come back to this part, the sensitivity and the specificity. If I get the right mix of signs and symptoms and looking back at how do you know it's really capturing that population, these criteria have a sensitivity of 85%, meaning they're going to be good criteria to try and make sure we don't miss anybody. The specificity is we could have cast a big net and we could have people in that net that really don't have the condition because the criteria might have been too broad. So the specificity is 69%. And as far as statistics goes, that's really pretty good. Much better than what we had prior to these criteria. Yeah. With any evaluation, a physician, a therapist, a provider is also thinking thoughts like, I got to rule out this. I want to look at red flags, things that really tell me I need to shift gears. I need to think of something different. This is more life-threatening. Your blood pressure is 210 over 189. We're going to stop right now and call the EMS or call your physician. So these are a list of red flag conditions that will come up first in a provider's mind that they're thinking to make sure they don't overlook, right? A spontaneous development, is there a fever? Is there abnormal neurological signs that may point to a nerve issue? Do I need an immediate test right now because this is looking a little more serious, more cancerous? Is there something more systemic going on? So there's a lot of those, and this is not an all-inclusive list, but we'll go through a little bit of these just to share some of the detail behind what your providers may be having to deal with on the inside of their head. The spontaneous development is actually a pretty significant red flag, meaning if it just happens very quickly with no warning signs, no development, nothing else started it, is this a spinal cord injury? Is this a deep vein thrombosis, a DVT, an infection? Is this a blood clot? Those really do need to be addressed pretty quickly, or else bad consequences happen. Is there another neuropathy going on? Is this a paraneoplastic syndrome, meaning a big fancy word for, is this something cancerous that's developing? A brachial plexus condition is a bundle of nerves. Typically, they tuck in nicely in the armpit, but they actually come from the neck and make their way down into the arm. For those with arm issues and arm conditions, that would be a pretty significant nerve injury that needs to be addressed and tested, because the treatment plan for all of these is very, very different. Another thought that may be for lower extremities or upper, if it's a carrying or a lifting that provokes the pain symptoms, weight bearing would be a walking or standing activity. It's like, my goodness, is there a fracture in here that hasn't gotten diagnosed? Is there some other condition of the cartilage that's degenerating? And I need to look at that, because if I don't look at it now, if we get more steroids in their system, that's going to degenerate the joint even further. Then I'm looking at a hip replacement. All of those other thoughts just kind of ramble in the back of your head, like I said it. Neurogenic claudication is a nerve condition. Vascular claudication is, again, vascular or blood clot. All of those would come up with weight-bearing issues. So, short story, hopefully. There was a case that I was seeing several years ago that was referred because the physician said, hey, this guy has complex regional pain syndrome. I spend maybe a week just working with him and doing some activities and noticing his pain pattern and what happens and what doesn't happen, what relieves it, how fast does his pain come on. He had some of those signs and symptoms. Yes, there were color changes, there was temperature difference, but the way that his pain happened with weight bearing and walking kind of really triggered me. And I went back to the physician and said, this is not CRPS, this is vascular. The gentleman had an amputation. He did not have CRPS. Um, so it's that serious and that critical that sometimes it does get missed, even though it's a red flag in the top of your mind. Um, thank goodness it takes a couple of sets of eyes to look at things and find these conditions. On the other side of the screen, inflammatory disease or a spreading disease, especially if there's a little bit of a history of arthritis in your background. Is this a polyarthritis flare? Is this a joint infection? Because the joints can get red, they get warm, they get swollen, they get painful. Some of it would start to match on the surface. So your providers are going to be drilling down on some very specific questions to rule some of these things out of the way and then focus more on some other details. And we're not done with red flags yet. There's a lot of busyness going on in our brains as we kind of talk with patients, get the information, go back and chart review. So in this case, if it's multiple limbs, especially if multiple limbs start at the same time, that sounds a little concerning. So in the back of the mind, to rule out conditions like peripheral neuropathy, and then look back at your personal history. Is there any other medication? Is there diabetes? Is there another prior injury that would provoke nerve problems all the way down to the hands and the feet that maybe started in the spine, started in your neck? So we've got to rule out those things to get them again off of the table so it clears the path to look further down the road. Small fiber polyneuropathy could be from multiple diseases. A different rare disease could be surfacing with those kinds of symptoms, or compensatory overuse, possibly from an injury on one side that leads to more use, more weight bearing and strain on the other side that's been bearing the weight and the load. Maybe it's a repetitive job injury. Maybe it's even just texting, typing. Back when I had transcriptionists that were doing all of the dictation for us, those conditions would rapidly develop bilaterally. It gets painful, it gets sore, they get swollen. So some of those overlapping signs and symptoms do give reason to cause us to pause, slow down, and not jump to conclusions. So once red flags are out of the way, we develop this idea of differential diagnosis. Now let's look a little bit deeper and make sure we can go through the weeds, through the signs, through the symptoms, and differentiate, is it really this, but not that? That's based on all of the things that you see on the screen, the clinician's experience, research reviews, the information that we get from ongoing studies, plus your history of what happened, combined with your past medical history. Labs, imaging, physical exam, and of course the signs and symptoms all come together to help differentiate, is it this, not that? Because in the criteria themselves, actually item number 4 says, and no other diagnosis better explains the condition. So this is a bigger list. Some of it looks a little repetitive from our red flags, but differential diagnosis, making sure I'm not missing a fracture, making sure I'm not overlooking other defects from the limb, maybe a bone spur, maybe a non-union. If there was a surgery, making sure I don't have screws in the wrong place that's irritating a nerve. So that could affect some of our limbs. I just had a recent case where there was actually a screw that was kind of pushing into a nerve in a person's spine surgery that was very, very much mimicking CRPS. And if the screw hadn't been backed out and the surgery repaired, that may not have gone so well for this person, but thankfully she's doing much better. Again, you see some vascular things, including lymphedema. It's a different type of a vascular condition that really does lead to a lot of swelling, pain, and difficulty movement. Raynaud's. You may have been kind of tossed around as having Raynaud's yourself in some of the differential diagnoses, where the hands get very cold, painful, sore, changes colors. And you can see the list again: autoimmune diseases, cancer type malignancies. We want to make sure we can differentiate, again, based on signs, symptoms, presentation, lab work, everything comes together. Last item, absolutely, psychological disorders to differentiate. Um, it can't be overlooked. It has to be on the table, but thank goodness it's on the bottom end of the list, right? In medical practice, when presentation, signs, symptoms, when there's not a test that says it's this, when there's not a clear-cut medical practice that says the condition is here, it's here, they really do have to put that on the table and consider it, but hopefully not jump to it. So we've got a couple of pictures on the screen. Hopefully the picture colors are the same for you on your side of the screen. There's one hand with a blue background, and our two hands are somewhat on a green background. Do you think both pictures represent cases of complex regional pain syndrome? Blue one that looks like the right hand definitely is the one of interest. We've got some swelling, it looks like, maybe some shininess, maybe sweaty on that palm of the hand, maybe some discoloration in there. So just on the surface look, without knowing anything else, we might be thinking complex regional pain syndrome. How about the two hands on this other side of the screen with the two pictures? Might have some color change. It might almost look like a red kind of a color for some swelling. It's kind of curling in a little bit, so that gives me some motor changes, maybe some dystonia. Do you think that one is complex regional pain syndrome? It'd be easy to think that. What I can tell you is the green pictures are actually not. That is actually palmar fasciitis and polyarthritis syndrome. So you just looking on the surface doesn't tell the whole picture, much like being patient with the physicians to go through their multitude of questions to help differentiate those kinds of things in your cases as well is really helpful. If, unfortunately, the two hands, our other picture, had been diagnosed with complex regional pain syndrome, imagine the course of treatment that would have followed. Let's try physical therapy. Maybe not such a bad idea, but physical therapy would be very different for CRPS than this condition. What about gabapentin? Some of these other medications with some pretty hefty side effects might be first line approaches if it was CRPS. Let's say the pain persists. What's your next option? Maybe some of us have had different types of blocks. Maybe that didn't work. Maybe they went into another stimulator or other more invasive procedures to try and treat this person's pain. But it really isn't CRPS. So pausing at the front side and asking all those questions, being able to really try and nail down the appropriate diagnosis leads towards better treatment. But sometimes treatment can be delayed. And that can be a very, very frustrating thing. This study gave us a few examples. On a prospective analysis means they're looking at patients in real time. We're going to take some measurements now and follow through the course of their treatment and just document how it progresses, right? So this one was after wrist fracture, and the cast had been on for about 6 weeks. After removal of the cast, it took an extra, 3 weeks for CRPS to be diagnosed in these population of patients with a radius fracture. So you add it up together, I'm sure during those 6 weeks, there were probably some beginning signs or symptoms that this doesn't feel right. So you got the 6 weeks there, plus the 3 weeks that it took afterwards. That's a 9-week delay. Could have been worse, yes, but 9 weeks is a big window that kind of makes a difference, doesn't it? And being able to proactively treat and get in there rapidly and start working through some of these issues. So the provider may have been thinking delayed healing complications. Maybe the person has poor blood circulation. Maybe they got other medical comorbidities. Vascular supply is just a little bit sluggish. Healing is compromised. Maybe there was a malunion, a non-union. We could second guess it all day long. But again, those are some of the thoughts that providers have to think so that they don't misdiagnose and mistreat. Was it just plain old lack of awareness? Did they not know the signs and symptoms? Do they not know how to compare left and right and what to expect as a normal course of recovery compared to what this may have presented with? A lot of good questions. Don't know that I have all of those answers, but I know there are some very, very complicated things up there. Another study that looked at delayed detection. This one was in Scandinavia, 52 patients. It took quite a while to get diagnosed. Their signs and symptoms were not even recorded in a couple of these cases. In 10 out of the 34, some of the autonomic abnormalities, what's that? That's the swelling, as the color change, the temperature change, the sweatiness or the dryness of the hands, changes in skin texture. We've got a lot of those types of signs and symptoms. It seems like that wasn't documented in a majority of the patients either for the first 4 months. It's just not good medicine. I don't have anything other than that to plug into there. We've got a lot of stressors. We've got a lot of broken people trying to help broken people. I'm hoping that that's not the typical case, but unfortunately, at least in this study and this review, it looks like it was pretty prevalent. It took a mean delay of what, 33 months? That's a long time to get diagnosed in this particular case. And then, of course, insert your story. We know in several cases it does take years. It's hopefully not that long now, but I think it still goes through specialist and then another specialist and then possibly even insurance delays. And there's a lot of barriers that I know you guys are struggling with. This was another sense of this just transparency that some of our providers are sharing with us now. But this was a study from 2016. 50% of the CRPS specialists reported at least some difficulty recognizing complex regional pain syndrome. So let that one sink in. The guys that we think of as being the specialists who really get this, they know the condition, they know what to look for. They're the guys that everybody refers to. These are the ones that are saying, there's still some difficulty in recognizing it. Why? Because it's a transient condition. And if you've experienced it for any length of time, you know yourself that one day it feels different than another. The swelling may change even from morning to afternoon. And with that, the color may be different certain times of the day. The variability just makes it so difficult to appreciate and experience yourself, plus to have a provider try and identify it objectively, because that's the best that we can do in that window of time that we're with you. So here's our short list of differential diagnosis. Yes, it is a much nicer list, but it has the different categories from the neuropathy things to vascular conditions, inflammatory dysfunctions, immunological issues, rheumatology, just downright bone issues in the necrosis or failure to heal or occult fractures and other things like that that can happen in our musculoskeletal system. The psychiatric causes. Thank goodness, again, it's on the bottom of the list, and some of those may drift into distress disorders or self-mutilation. What does that mean? That people induce this on themselves. It may sound crazy because you know how bad this hurts, and you're thinking, who would want to do this to themselves? I've seen a few cases over the years where that has proven to be true, and I don't have that answer either. But since we've kind of wanted to pull in on this, let's walk through a little bit of it together. Like I said, we cracked the egg. Let's see what we can come up with. First and foremost, let's recognize that those experts, the specialists, and the ones that we refer to as the go-to guys in the literature, They agree that complex regional pain syndrome is not a psychological disease, but psychological aspects can't be ignored. This is a distressing condition, especially when it goes on for months and years, and there's treatments that are supposed to work but don't work. When there's changes in lifestyle, jobs change, family conditions change, finances change because jobs change. And I'm not telling you anything that you don't know already. But those kinds of issues really do make it all the way into the heart, and that is hard to deal with. Again, self induced disorders are well documented. Another psychological condition. And once we walk into this, providers are trying to be a little bit savvy to recognize it because that approach is very different than what it would be otherwise. Some of those psychological factors are here on the screen: anxiety, catastrophizing, fear, histories of past abuse, and depression or mood disorders. The factors that we're looking at are not just mild. These are pretty significant conditions that not only play at the heart, but they change your physiology. Um, if you're not familiar with the word catastrophizing, think of what a catastrophe is. That's a seriously bad event. 9/11 would be a catastrophe. Um, so thinking of and considering a health condition as um, unbearable, as I can't live through. Um, Catastrophizing is also thinking of the worst outcome and thinking about the worst potential, even though you haven't tried to move into that direction yet. An example would be if I'm asking someone to just start touching a towel, start touching their own shirt, start touching their own leg, and let that hand feel something different. But if they're so worried about what it may do, what it may feel like, I'll never get over it, I can't do that, it's going to make my hand worse, it's going to swell up as soon as I do it. If that's like the same recording in the head and they're catastrophizing over the what ifs, that really contributes to the fear of doing something. It holds back from the potential of doing the thing that may actually help. So catastrophizing is a big barrier. How do those psychological factors affect the physiology? Anxiety and depression, when they get to being in a significant amount, really do change the neurotransmitters in your nervous system. Those transmitters in the nervous system change to a point where they increase the pain sensitivity. So it's basically a change in chemistry, which is why medications are sometimes on board to try and reduce the depression, anxiety, and some of the medications do have a crossover effect to reduce those symptoms of anxiety, depression, but also help with some of the pain at the same time. Catastrophizing, like I said, when I'm already predicting a worst case scenario that builds my fear of an activity and builds my fear of a movement pattern, chances are I'm not going to do that movement. It's just that powerful of a force. Well, we know if I stay still too long, I create my own cast. And when that happens, I get even more pain, more stiffness. And because I'm not moving it, vascular flow really does slow down, and I get the colors and the temperatures and the swelling. This was a nice study to pull in. It's a little bit old. I think it was in 2016, but I still like it. Um, these guys followed patients who were going for a total knee replacement. They also looked not just at the physical x-rays and what surgery are you having, they kind of looked into some of the anxiety issues, measuring anxiety, measuring depression with some questionnaires that you may have seen yourself over the years. And they were thinking, does the anxiety and depression before this surgery indicate a chance of these people developing complex regional pain syndrome afterwards? Well, the rates of CRPS were twice as high in those who had elevated preoperative distress. But Look down at the second paragraph down there. In spite of that 1 month prediction, at 3 and 6 months, that wasn't so. So it may be a vulnerability, it may be a risk factor, because we know again that anxiety, those depressions, those worries, it changes the chemistry that just makes your body different. It makes it susceptible, but it doesn't have to be stuck there, right? In the article, there was no indication that these people had any different treatment other than everybody else going through a knee replacement. So their change wasn't because they had a different treatment. They didn't do desensitization. They didn't do weight bearing any different than they would for the next guy with that same procedure. Since it's on the list, psychological factors that lead to a person inducing this condition on themselves, I can't imagine. I do know it's got to be very distressing what they're going through, what they're facing, some decisions, some losses, and maybe it's just their attempt to try and make something different, right? It maybe I have no clue. A cry of help, maybe it's financial, maybe it's secondary gains of some sort. I've seen it occur from patients who are doing tourniquets to themselves. I've seen some other ways of inducing this around um, a minority population for sure, but it's still part of the puzzle that I'm sure kind of swims around some of the heads of providers when they're looking at cases that they can't understand either. Now we come to a different condition diagnosis, a somatic symptom disorder. It really is a standalone diagnosis. It is a psychiatric condition, but it does have at least one physical symptom. It's really renowned for having a person with excessive thoughts and somatic focus. I can't stop thinking about a hand, a foot, a stomach, whatever that symptom is. The behaviors are also related to their physical symptoms. I'm not doing what I should do. I can't get out of bed. I can't eat. Some of those behaviors to that point are very different. So when we put the two side by side, just for a quick look, somatic symptom disorder and complex regional pain syndrome on the other side, for both of these, there's no definitive diagnostic test. There's not an X-ray, there's not an MR, there's not another scan. Both of them do come with some psychological baggage, one much heavier than the other. Both of them, however, need to be investigated further and pull in other consultants. Maybe I need somebody else to look at the stomach and see if there's a real issue in the GI system. Let's look at another nerve study and make sure we're not missing something that could contribute to one or the other. It definitely muddies the water when we get into those kinds of cases. So the case that comes up to mind is this one. It was a 16-year-old male. He was in high school, training for Olympic weightlifting. He had Crohn's disease. If you've seen that name or that diagnosis before, it's a stomach condition that's really doggone painful. But thankfully, this little guy was in remission. But in his activities, he had a flare up of some bilateral leg pain. Along with his pain, he was getting numbness and tingling and burning and color changes. And just so happens, this young guy was also quite anxious. The article describes him as having massive anxiety that was paralyzing, like deer in the headlights. I don't know what to do. I can't do anything. I'm so anxious, right? A lot of social anxiety, a lot of medical anxiety. He appears to have gone through a lot already medically with the diagnosis, treatment, and finally getting in remission with his Crohn's disease. And now this other condition creeps up and it just kind of knocks him off of his rocker and unsteadies his course. So he had a list, a litany of different specialists, but that's why they're there. We needed that differential diagnosis, right? Let's rule out something in the GI system. There were some skin changes, some color changes. Dermatology comes in, immunology, rheumatology, and pain medicine. At the conclusion, he was diagnosed with a complex regional pain syndrome condition. Physical therapy, cognitive behavioral therapy did wonders. He was able to recover and get back into his routine at school. He was able to go back to weightlifting, no residual impairments, and no to minimal sensitivity in the legs. But you could see how maybe some of that previous history of medical challenges, the worries, because that was a pretty painful thing for a young guy to go through. Um, and and all of us, we've got some degree of anxiety on a spectrum. I've seen a lot of young guys now, young ladies, social anxiety, medical anxiety, too scared to talk. And then you put in the unknowns and the not being able to understand all of what's going on medically, and maybe also challenges that we just can't appreciate at families, homes, and schools. So, with this somatic symptom disorder, I want to say versus complex regional pain syndrome on the same screen. We're really familiar with CRPS, but drift over to the darker gray, looking at somatic symptom disorder. It's a broad range of physical symptoms. They would cause distress in most any of us, but these symptoms could include more GI, more neurological complaints. The excessive thoughts and behaviors are paramount. It appears in this disorder that those thoughts, those worries, ruminating over the same thing becomes kind of the bigger barrier than the gastrointestinal, the neurological, the pain itself. It's like the psychology trumps the physical on this condition. Emphasis is on psychological factors. Psychological treatment may be a very well needed resource for this population. In the middle, we try to differentiate again, differential diagnosis, one versus the other. The differences could be that both of them do have physical symptoms, both of them do have some psychological challenges, but it's not that the psychological challenges caused the signs and symptoms of complex regional pain syndrome. Reverse it, maybe, because there's been such physical challenges with CRPS, there are some emotional struggles, some depressions and frustrations. CRPS acknowledges that the psychosocial factors can impact the progression and the severity of pain, which is why that biopsychosocial approach may have a few other providers in your care team, and one of them may include counseling or psychology. Both conditions emphasize the interaction between mental and physical health. Oops, too many. Different term, different diagnosis that you may or may not have heard as well. Functional neurological disorder. This is nothing new. It's been around for centuries, but like CRPS, it's gone through different name changes. Uh, but the definition is that there are one or more symptoms of varied, altered, atypical movement patterns or sensory dysfunction. Clinical findings are incompatible between the symptoms that are presented and other conditions that present with, right? What that means is, let's say a person has some shakes, some tremors, a different gait pattern. It kind of almost looks like somebody with Parkinson's disease, but everything else that they present with doesn't match Parkinson's disease. Their gait and the type of tremor that they present with, it's not Parkinson's, right? Um, Pick up any other diagnosis, somebody with a brain injury or vestibular dysfunction, some of our vertigo cases, it kind of looks like, but when you start to really look at the details of how they perform, the timing of signs and symptoms and how it responds to distraction, how they respond to testing, how they respond in different environments, it's not consistent. And the last bullet, the symptom or deficit is not better explained by another medical or mental disorder. Very confusing, for sure. This is another condition that does not have a specific imaging test or a blood test to point to it. So therefore, it kind of goes into that odd category of a rare disease. Symptoms of FND could include any of these. not all of them, right? But somebody may lean more towards a weakness and paralysis presentation that leads to maybe a different gait pattern. Somebody else may present with tremors and difficulty to open their hand because it stays clenched into a fist. Some may have sensory loss or sensory aversion, meaning everything that touches them hurts. There are cases with non-epileptic seizures that fall into this category, and pain could be a standalone condition or it could be combined with any of these. So there's a wide range of how this condition presents. What is interesting is that when you lay this next to complex regional pain syndrome, it gets a little fuzzy. And that's exactly what you've got here on the screen. You've got one side that looks at a set of criteria, and another side on this side of the screen. The question is which one is CRPS and which one is functional neurological disorder? And there's our answers. It's so close, right? So I think when some of these conditions really do define themselves close to CRPS, it adds to the difficulty for our healthcare providers to differentiate which is which. Altered movement patterns with complex regional pain syndrome, there may be tremors. There may be feet or hands that don't move when you want them to. Um, It could be, it used to be a sprain, it used to be a strain, but now what I'm presenting with, this is not what it looks like. There's color differences, and a simple ankle sprain doesn't have so much color difference. Um, so comparing and contrasting how the condition changes over time, plus also looking at other possibilities. Some of the literature gets a little spicy. So just to share it with you, this one says, although CRPS is a diagnosis of exclusion, the same symptoms would require a physician to at least consider FND. Treatments are different between these two. This goes right back to why do we want to make sure we try to get the right diagnosis at the beginning so that we can get the right treatments on the back end. Um, the population with functional neurological disorder would not bode well with some of the invasive procedures that go along for complex regional pain syndrome. Some of the medications would be quite different as well. Here you can see a wide umbrella, a wide net of different types of functional neurological disorders. And again, because it's kind of being tossed around there in the literature that some of the presentations of even fibromyalgia and CRPS may be a little bit underneath that umbrella. Still debated in the literature. There's no shift that I'm seeing. It's just nice editorials and things like that. We go all the way to the other side of the spectrum where there really are some providers and researchers who are discounting the diagnosis of CRPS. Um, some of their ammunition is that you can't find a common biological mechanism. There's not a single thing that's consistent across all diagnoses that says this is what happened. This is the cause of the signs and symptoms presenting as they do. There's a huge variability in those signs and symptoms. Like we said, you've experienced it. Some days are better, some days are worse. And even the same day could be different morning to evening. They cite poorly identified criteria as their rationale to discount the diagnosis itself. And they indicate that there's no effective therapy, so the condition should not have its own diagnostic category. Sometimes we've just got to be comfortable with a little bit of gray. And right now it's looking like they want to make this a real black and white issue. Some of the literature has really gotten spicy as well when I look at this one. Um, so these guys went back and they looked at over 1,000 articles and they pulled out only 9 that were good, but even those good ones were of low quality. What do they mean by low quality? It means they really didn't have a strong argument. They did not nail down signs or symptoms or medical conditions that they were trying to approach and compare to. They didn't have any backup resources or references in their article. And you can see the ones that made the top 9 list were only narrative reviews, personal views, editorials, and such. But their arguments against CRPS. It says that these symptoms are normally seen after immobilization anyway. Well, kind of, sort of, but not, right? After immobilization, there is some stiffness, there may be some swelling, but it doesn't persist because the normal course of healing and recovery is it gets better. This is not the case. Other causes could explain the presentation. Okay, name one, right? I'm kind of being a little bit crazy with it, but psychological factors cause CRPS? Absolutely not. We've seen other specialists and experts that say the opposite. The pathophysiology is unclear. You know what? I got to give them to that one because we really, again, don't have a single cause and effect that causes CRPS, but we've got a lot of good theories that we're working with, and we know so much more now than we did 15 years ago. Weakness in methods of research. Okay, fine, but that's kind of describes a lot of some of the literature out there as well. Again, the disagreements with CRPS, they say that the term complex regional pain syndrome does not indicate the underlying pathology. But you know what? That name was intentionally selected years ago at the Budapest conference because before that it was reflex sympathetic dystrophy, and that name itself implicated the sympathetic nervous system to be the thing that went wrong. So a lot of people were just getting sympathetic blocks and not getting better because the treatment plan was not holistic. They weren't looking beyond that one piece of the pie. So the name was intentionally given as it was because it is complex. There are different treatments, different presentations, and the name was intended to not misdirect to something that may only be a part of the problem. Another bullet point is that it medicalizes non-specific symptoms. Yeah, that one kind of didn't make sense to me either. Those symptoms, the vascular changes, temperature changes, swelling, when you combine all of those symptoms together, that actually develops a syndrome. So they're a little bit discounted by that one as well. A nocebo effect is the opposite of a placebo. A placebo is I give you something, you think it's going to help, and it does because you thought it would help, even though it was a fake medicine. The nocebo effect for this intent, this framework, is you read about a condition, you think about the condition, you develop the condition, right? There's no research to support that. With the idea of a unclear pathophysiology, we know that there are some possible mechanisms from the autonomic nervous system, central nervous system. All of these systems working together tend to contribute to what the final presentation is. It's a continuum, and it's a wide varying continuum. The psychological factors. CRPS is caused by psychological factors. Again, it's been refuted in other literature. The idea that just inducing the signs and symptoms because you know about it, you read about it, is not holding weight either in some of the more expert literature. And then looking at psychological or secondary gain issues, but potential for any condition, not just complex regional pain syndrome. Some of the experts from some of these articles. Traditionally, physicians endorse that pain without a physical cause is psychological. And just realizing that that is the medical community model. They look for something that is concrete, objective, repeatable, consistent, dependable. And they need that to kind of endorse their medical plan and diagnosis because 1 and 1 should always equal 2. This is not such an easy condition. It doesn't mean that it's psychological, but in the training, in the mantra, in the background that has to surface up. And I think some physicians may lean in that direction faster than others. Pain in the absence of a definable biological process is psychological. Unfortunately, that is also another thought that circulates within some of the healthcare providers community. Pain can be an expression of anxiety, depression, and other psychiatric conditions. And that one actually is somewhat true. Anxiety, worry, depression, when it escalates to a significant degree, can absolutely bleed over into some GI issues, into some headaches, into some migraines and such. Does it mean we ignore the physical symptoms? Absolutely not, but we treat the entire package. Pain as a psychological sign does not deny the genuine nature of pain. Absolutely true. Um, again, considering the entire biopsychosocial model and looking at the origin of the pain and how that person has had to go through so many struggles and frustrations that do affect the heart. So now what? Let's look back at some action points, or what do we do with this information? Because it is confusing. We appreciate the physicians are struggling to identify the condition, a lot of differential diagnosis going on in their head, and even experts are continuing to admit the transparency that it is a challenge even for them to correctly identify this condition. So in your medical appointments, plan ahead. Get detailed records of the pattern of your signs and symptoms. Uh, we've got the smartphones now, and that's been kind of a nice asset to be able to demonstrate and show what we can't see because we've only got such a short amount of time with you. And being organized in that presentation of your information and being succinct. You know how quickly they're going to come and go in that office with you. So again, planning ahead of time so you get your important information out there. You know your body, you know your signs and symptoms, you know how it feels and presents. So being able to express that in an organized way helps them to kind of process that information. However, as we saw at the beginning, there's a good bit of information that that healthcare provider wants to take off the table first. They want to unload some of those red flags. So kind of flow with them in their set of questions. And you'll probably see that the next time you're in a new physician's office, how they need to take and take care of those red flags and then drill down and be more attentive to what the current signs and symptoms are. Ask questions, absolutely. And actually have them written down, have a few ahead of time. Ask to have them repeat something if you don't understand the way that they're saying a piece of information or they're making recommendations. Actively listening so that you can kind of remember that and be able to ask questions based on what they're telling you instead of using that time to plan ahead what your next question is or what your next thing is. So having them written ahead of time would really help that communication be better. And then developing that partnership with the physician. Coming in with a fresh perspective. No doubt there's been some struggles with past providers. So allowing that to be a past provider so that you can meet the next person with maybe a fresh set of eyes. You've had your condition for a length of time, but if this is the first time that the new physician, the new therapist is meeting you, they've got a lot to take in as well. So just being patient with them, I think, helps as well. And sharing resources. You saw on the first slides that some of even our specialists are like, I'm struggling with this, and some of the information would be helpful. Print out an article, leave it. If you don't mind, I've got this that might help and shed some light on what I think I'm feeling, would be a welcomed piece of information. Considering how both the physical and the psychological things really do work together inside everybody. And it's not just chronic pain. Some of our acute pain conditions also struggle with some of these issues. But putting the package together, as I say, is a nice way to look at it. If you go back to the RSDSA website, over on the side, there is an advocacy tab that comes out with 10 tips for patient advocacy. That is a really good resource to look through ahead of time as you plan to make your next visit. And research, yes, you saw how this is still a rare disease, and it's difficult to get meaningful research when there's only 100 people with this condition, when there's only 80 people that a certain academic institution can reach because of their geography. So go to this website and you have a way to look into a search feature and look for research on complex regional pain syndrome. It'll pull it up for you, different cities, and it may even have a couple in different international countries. But if you happen to be in the neighborhood, or maybe they're doing something in telehealth as well. We could use all the information that we could get to further some of the literature that we're trying to read and study. Another one that may be closer to home in the United States is a Rare Disease Advisory Council. You can see the map and where these councils are. These are housed underneath the Department of Health in most of these states. And this is a council that's typically made up of healthcare professionals plus patients and other providers. Caregivers are even in some of the council here in Florida. So it's a council that's developed and meeting to try and advance the cause of all rare diseases. And again, CRPS is one of those. So look it up. Some of those, some of those councils that'll have monthly or bi-monthly meetings may have a way to log in and be a visitor in one of those meetings, or look at the requirements to be on the council would be another fabulous way to get into it. So hope that may have been a little bit helpful. I am thinking we're right on time. So I'm going to close this out and see if there's anything else from here that I can help you guys with.
Yes, yes. Thank you for this presentation. I know we've had a lot of questions and comments in the chat. I know we had a few people who joined at different times. So I know some people have mentioned that, they weren't at some points, maybe they were a little confused, or they wasn't able to really follow. So I just wanted to kind of clarify a few things, since we did have people join at a few different times. So you're saying that, of course, CRPS is physical and it has psychological aspects as well. Right. Yeah, there's some questions in here. People are, like I said, I think some people are hearing you and they're thinking that you're saying that it's only psychological, but I just wanted to clarify that,
No,
recognize that it's both.
no, because the gist of it was, why are we getting diagnosed with psychological things?
Right,
And I think the providers a lot of times will lean in that direction too fast.
right,
Um, but I don't want to say for good reason, but that's part of their training. That's part of their mantra. It's like, go to here, go to here, go to here. If nothing fits, then go here. And they may be jumping over that line a little bit too fast.
right. So I just wanted to clarify that, because I think we had, like I
Thank
said, some
you.
questions.
Yes.
I wanted to start there. So thank you for that. We did have a good question that popped up when you were on the psychological factors slide. So how are the items that you had listed? And I wish I had taken a screenshot because it was a while ago, but how are the items you had listed any different from any other neurological and chronic condition? So like, have you found that CRPS is singled out as far as this psychological assumption goes? Like, is it really just CRPS, or are other conditions also being put into that box?
Great question. It was probably the screenshot with anxiety and catastrophizing and fear and those things, right? That is universal. So treating chronic pain for over 30 years, it's a continuum. Some people have more of, and some people have less of. But those factors are there for chronic back pain, for failed back syndrome, um, migraine headaches, people who have concussion symptoms that just kind of linger for long, long, long time. they also develop the catastrophizing. I'm fearful of, and I don't know, and I can't because it hurts too much. That's a real variable because it's really hard to work through some of these things. And sometimes that becomes the sticking spot that you can't get over until you put a whole team together to work through.
And I'm glad that you started out, walking through the thought process for diagnosing and treating CRPS, because I know obviously in the USA Today article, which I did link in the chat if anyone's looking for it, I read that the average CRPS patient will go undiagnosed for nearly 4 years. There were a few people in the chat, women in the chat, who said, it took them over 2 years. Someone said they were misdiagnosed for 13 years. So I think my question is, how can knowledgeable physicians and organizations like RSDSA change that? Like, how do we all come together to help others get an earlier diagnosis?
I really think the Rare Disease Advisory Council is a great avenue, um, because our mission is to increase access to healthcare and to increase the education to providers and healthcare providers on all rare diseases. So having those voices in those councils that say, hey, don't forget complex regional pain syndrome, would be a great asset. Um, we are looking at different ways to help those providers and get information to them so that they can move in those directions for whatever diseases that they're looking at. Um, the other thing, like I said, is just being a prepared advocate. Um, sorry, I'm getting a pop-up message over here that says my system's going to reboot. Not now.
No.
No, you're not. Um, sorry, leave it over there. Um, how can we help? Yeah. Being an advocate as you meet your new providers, sharing maybe some soft literature that you've seen that helps to point them in that direction. And some of those councils I think would be a great asset.
Okay. We did have one question that came in. Someone asked, how do you tell a pain doctor that his PA is, telling them that normal people can handle your pain every time they go into the office? People obviously don't want their physical illness, like, they don't want their physical illness like undermining their condition, and their lived experience. So it's like, how do people best talk to their doctor when they have CRPS and their other people in the office are not believing them?
If it's a good relationship with that primary provider,
Mhm.
um, maybe at the onset of making the next appointments, try to get that appointment just with that provider. Let's just shortcut seeing that second provider, the assistant or the resident or something like that. Try and go straight to the one that you've got the better relationship with. Um, the other one is if you really have a good relationship with that provider, ask them if you can share some information about how you feel you're being treated with the staff. And
Mhm.
just being vulnerable and honest with them. Again, be sure you've got a good foundation to work with from, because you don't want to become confrontational with somebody that's your main resource. Going out to find another provider is really challenging. You took time to find the first one to begin with, so it is a delicate conversation to have.
Right. And just as a reminder for everyone, who may be looking for a new physician, you can always reach out to us and we can help you find a new physician in your state. We have people who reach out and they are in Florida, but they want Georgia and South Carolina and Alabama and Mississippi too. So we'll send you lists for the region and try to help you find someone that can definitely help you out. And I think the last question, I know we've kind of touched on it, but I think this is a good question to kind of end on overall. How can CRPS warriors best advocate for themselves before, during, and after their appointments? Kind of like as a general summary of everything.
Um, some of those advocacy things that were on the RSD site, feel free to go there. Absolutely. Um, Being able to maybe take somebody with you in case you lose your thought, you lose the words, you hear something that just kind of distracts you. You know, they're going to share a lot of information with you. So feel free to then take somebody that can be your backup voice. And sometimes it does help to have somebody that you know that you trust to talk with you, talk for you if you get kind of stumbled over yourself in some of those word finding challenges. Because pain is, it can challenge how you think, how you present, how you can find words and stuff like that. So be prepared in that sense as well. So that's kind of before, and then that's kind of during how you can advocate for it. And as far as afterwards, I think some of those other resources just kind of look out for each other. Um, get information from other warriors. We've got some of the support groups around, some of the networking thing that's going on, and try to enhance from that side and increase the awareness. Looking forward into November, CRPS Awareness Month, find a way to be an outlet for that, even if it's just wearing orange or asking if you can put up a flyer, because I know Color the World Orange may have examples and ways to help promote that as well.
Definitely. And I'm glad that you did share that screenshot from our blog from our advocacy lead, Lisa Van Allen. We're always looking for new members for our advocacy committee. So definitely have some additional tasks and ideas that I'll be sure to send her in the morning if she's not already watching, because we're always, like I said, trying to find different ways to reach out to people. Of course, we have these live streams, we have conferences, we have so many different resources on our site, but it's just trying to figure out the best way to reach the most amount of people so that CRPS warriors can get this early diagnosis, they can get their treatment. So,
Absolutely.
um, yeah, I definitely want to thank you for all the work that you've done for CRPS, for RSDSA over the years. Like I said, this is not your first time joining us for a live stream. And I definitely know I've already seen people in the chat saying they're going to rewatch your live stream tomorrow, just to learn a little bit more, maybe catch some things they didn't see the first time. So I want to thank you for joining us, and thank you for everyone who's watching on live stream. Be sure to visit our website for tons of resources, all the different resources that we mentioned on this call. Send us an email at info@rscs.org. If you need a physician's list or you need any other support from RSCSA, we are here to help. We get so many emails and messages a day. I'm checking them as quickly as I can. So definitely please be patient with us, and we will get back to you and help you out. But yes, thank you all for joining us, and we'll see you next time.